Hi, in this video, I'm going to be talking about screening for breast cancer, doing a comparison between mammography and MRIs in screening for breast cancer. Before I go on, I want to encourage you to subscribe to our channel. Even if this video doesn't ring your bell, we put out 3 videos a week, so it's very likely that you'll see something that's of interest and of use to you. So let's talk first about screening, what it is, what it isn't, and then we'll get into talking about mammography versus MRI for breast cancer screening. So screening is a form, and when we talk about breast cancer screening, of early detection. So this is not prevention, it's called secondary prevention. So it's not primary prevention, keeping the cancer from developing in the first place. Rather, it's detecting it before it leads to trouble. There have been thousands of studies of mammography for screening, fewer of MRI, and I'll get to why we do one or the other. But screening has been shown to detect cancers earlier than if they're found when people are symptomatic. And what I mean by symptomatic is having a lump, having somebody detect a lump, like on a doctor's breast exam, or somebody else on the medical team doing a systematic exam of the breast, or presenting with nipple discharge or other changes in the skin. So those are symptoms from breast cancer. And screening, the goal is to find the cancer before it's symptomatic. Now, not all cancers are amenable to screening. We don't screen for very many cancers. We don't screen for most cancers. In fact, we screen for breast and lung and colon and cervical cancers. That's really about it, unless somebody's in a very high-risk group for another type of cancer. And the reason is because for screening to be effective, we have to find the cancer and be able to intervene and change the outcome than if we hadn't screened. So if you have a rapidly growing cancer, and that includes a rapidly growing breast cancer, and you are doing a screening in May of each year, and the cancer starts to be detectable a month later and grows to be quite a large size before the next mammogram, mammography was not useful in that person's case. And that's the case for most cancers. So, for example, we don't screen for ovarian cancer because we have not shown that detecting it doing a test at a particular interval catches the cancer earlier to change the ultimate outcome. And as I mentioned, for some breast cancer, screening is just not effective because the tumors are more rapidly growing, and we don't want to be doing mammograms too often because it's a form of radiation, and we don't want to expose the breast to unnecessary radiation. So screening, again, is done to detect cancer when it's early enough to intervene and improve the outcome, compared to if that person had just had that cancer detected on exam, their own or by a healthcare professional or a partner. Breast cancer screening is effective, particularly at the population level. So if we take tens of thousands of people and we implement a mammography screening program in particular, it's been shown to save lives and to be cost effective. Now, there are changing guidelines for when mammography should start. The younger somebody is, the less likely they are to have a breast cancer that's going to be screen detected. So recent guidelines in the US, anyway, have recommended screening starting at 40, when before they'd been start at 50, discuss with your doctor if you want to start screening earlier. There are a few problems with starting screening earlier. The first is that the prevalence of the condition is so much lower that we're more likely to be doing tests with no yield than we are in older people, 50 and over. And I often use the age 45 as a cutoff, because that's actually where you start to see a bit of a jump in the prevalence. How many people, if I go out and screen 100% of people in a population, how many people will have a cancer detected by a given test? The other thing to know is that not all studies have shown that this is cost effective at the population level. There are a lot of arguments against screening earlier because the downsides are we miss a cancer and people then feel something and say, well, my mammogram was normal a couple months ago. Or we see more downsides, unnecessary procedures, worry, peace of mind is disrupted. People have a cancer scare when really there was no cancer and maybe even no need for them to have the test. So that's on the side of, being more conservative and who gets screened, taking the population vantage point. Screening in people at higher risk, people with an inherited susceptibility to breast cancer, like an inherited gene from one of their parents, or people who've had radiation to the breast for another cancer, or there are still some people who walking around today who were exposed to radiation when radiation was used, believe it or not, for acne on the chest and the back, or people who had their thymus radiated, that's in the center of the chest, when they were very young. And those people were exposed to very high doses of radiation therapy and are at risk of developing breast cancer because of the radiation therapy. And then, of course, there are people who are having appropriate radiation therapy for Hodgkin disease or other tumors in the chest area. And that radiation exposure, particularly in a developing breast and the prepubertal, early puberty, and puberty years, will have a higher risk. Those people need to have, if you're one of those, you need to have different screening recommendations. We start early, and because we try not to use x-rays on young breasts, we will often lean towards other imaging like ultrasounds or MRIs until people are over the age of 30. I've talked with people who've told me I've had a mammogram every year since I was 30. Why did I get breast cancer? And although I can't tell you how many people in a given population are at risk of breast cancer from that much radiation, if you think about it, getting radiation once a year from when you're age 30 until, let's say, you're 50 or 60 could conceivably increase your risk of getting breast cancer, when what we're trying to do is detect it early and affect secondary prevention. Again, those cases are few and far between. Most people do not start mammography, x-rays to the breast, until they're over 40. In people with a strong family history, we try to alternate mammograms with MRIs to decrease the amount of radiation exposure that they have. Overall, the amount of radiation you get with a mammogram is very low dose, about the same as taking a flight. Even a short flight will give you more exposure to radiation than will a mammogram. So I'm going to go a little bit deeper into mammograms. These are the tried and true tests. If we could get everybody who's eligible in the world a mammogram, we would save more lives than by many of the advances that we crow about and are so proud about in medicine. Really just, what sounds so basic and elementary is so powerful a tool in terms of improving population health. There are countries where mammography is not available, or where that's what they have and they don't have access to frequent enough mammograms. What about the frequency? For people who are not at increased risk, maybe every other year is sufficient, but as an oncologist, you won't find me recommending that to many people. Most of my patients are diagnosed through a mammogram, and because of that shorter window of time of development, I do err on the side, when friends and family ask me, towards an annual mammogram. Other things about mammography, it can be uncomfortable. It's a compressive technology. So for those of you who haven't had a mammogram yet, the breast is squeezed between two, they're not glass anymore, but two glass-like plates, both top and bottom, and then side to side, and then sometimes it's called the Cleopatra pose, where the breast is squeezed sideways like that. So that can be uncomfortable, and it's often recommended that you cut out caffeine so that it's less discomfort for you. It feels like your skin is being pinched. Lots of people, and this is something you could ask your doctor about, take something like a non-steroidal anti-inflammatory drug ahead of time, and that can make it less painful for you. Most people I know do not describe it as pain, but rather discomfort. But I've had plenty of people tell me it's painful. And when I talk to my husband about it, I definitely tell him it's painful because I want a little sympathy. So mammograms are very sensitive and also very specific. So when we see an abnormality that looks like cancer, we can be pretty sure we're not picking up a lot of benign lesions. They are less sensitive, that is more likely to miss true cancers in people with dense breasts. If you have had a mammogram, your report will tell you if you have dense breasts or not. It's not based on how they feel. Surprisingly, a lot of people think that they can feel their breast tissue and say whether or not they have dense breasts, and that's actually not the case. It's a X-ray characteristic of the breast. So, and then the other thing that can be very tricky is for people who have posture where they're bent way over, that's called kyphosis, or other mobility problems. It can be difficult for them it can be difficult for the machine to accommodate them. So people in wheelchairs can have mammograms, but if people have really difficult posture, when you're really bent over, that's called kyphosis, that can make it difficult to image the breast very well. So that's mammography, tried and true, cost effective in most analyses, generally what we recommend for the general population. Now, if your breast cancer was missed by a mammogram, you probably have strong feelings about what I just shared. Many people have commented that there are some cancers harder to see on mammograms, like lobular cancer, and that's the case, but lobular cancer is uncommon. So as a population screening strategy, mammograms are the gold standard. Next, I'm going to talk about MRI, which stands for magnetic resonance imaging. The way MRIs work is by using magnets actually to spin molecules in the tissue. We can do MRIs of any part of the body. When an MRI of the breast is done, we use a dedicated coil specifically to look at the breast. MRIs, if you've had one, you know they're quite loud. They take a bit of time. They are not compressive. So they don't require that the breast be compressed, which is an advantage, but they do take quite a long time. And one of the main disadvantages, well, actually there are two that factor into the current recommendations for breast cancer screening. One is cost. MRIs can cost a couple $1,000s. So for insurers, this is not something that they can do without passing on much of that cost to you, the subscriber, to the population. And in countries or in people who don't have good insurance coverage, you can imagine this would not be a feasible strategy. The other thing about MRIs that makes them not my favorite, sort of in the con or against column for MRIs as a screening strategy, is that they are very likely to pick up things that are not cancer. And this can actually lead to delays in your having appropriate care. So if you've been through this story, and I know many of you watching this have, you had a mammogram, then you had an MRI to clarify something or for pre-treatment planning, you've had an MRI, it shows things that weren't seen on mammogram. And while that sounds like a good thing, most of those are not cancer, and yet we will go chasing those. Unless we can be 100% sure that they're not cancer, you're going to end up with a biopsy and maybe another biopsy and then maybe another biopsy. This has been shown to delay treatment by up to a month or more because of that chasing of these abnormalities that end up being benign. And then another downside is that for us to really understand what that lesion is, we often need to give contrast. So that requires IV and then contrast, which is unpleasant when you get it. It can taste funny or make you feel funny. And for most people, it doesn't cause any problems, but there are some people who can have severe reactions to the contrast. So on whole, we err on the side of recommending mammograms. I'm going to go through some exceptions. So MRIs, we do recommend for people with an inherited susceptibility to breast cancer, people with an inherited mutation. We recommend MRIs as well as mammograms, not instead of, but combined. And the thought is we can alternate them or do them the same around the same time to get even more information. Remember, these are people who have as much as an 80% chance of getting breast cancer in their lifetime compared to a 13% chance in the general population. Yes, it's 13% too high, but 13% compared to 80%, you can see why the downsides of MRI will be offset by that increased yield of MRIs in people at high risk. People who are young, who had exposure to radiation therapy as part of treatment for another condition, who are very young, we tend to lean towards MRIs if they're available in the area. And we will, if you have insurance, we will work with your insurance company to get them covered, because we don't want to expose very young breast tissue to x-rays, and because MRIs are so much more sensitive in a group of people much more likely to get breast cancer than the average population. Sometimes we are just so befuddled by a mammogram or a physical exam that we end up doing additional imaging. That might be an ultrasound or an MRI, but again, that's not screening. That's looking for an explanation for a finding that we have. If I do an exam on you and I don't see anything on imaging and I'm concerned on the exam that this doesn't feel right, I'm going to do further evaluation. Again, that is not screening. Screening is people with no symptoms, where I'm trying to detect a cancer before it's symptomatic or something we can feel. I hope this has been helpful. I know I've covered a lot. I welcome your questions, your comments, share your experience. Everybody's story is different, and you will find that even in your community, recommendations vary. We try not to see variation like that. We don't want the care you get to differ according to whether you're treated in one zip code or one state versus another, or one part of the country or one part of the world or another. That kind of variation means that probably some people are getting too much of a technology and some people are getting too little. We like to see care harmonized and matched to your need, to the clinical indication, not to enthusiasm for a particular test, or that's just how we do things around here. So comments or questions are welcome. Don't forget to click like and subscribe, follow us on Instagram, and thank you as always for watching.